I am the youngest of 7 brothers and 3 sisters. And when I was 10 years old, my mom, she died from breast cancer. And not until her death did I know what she died from. It wasn't discussed. Then my oldest sister was diagnosed with breast cancer, and so was my dad. And then there were 2 brothers, 2 sisters, a niece. Now that's a lot of people.
Cancer was ravaging Tallulah's family, and yet, as she says, it wasn't discussed until, that is, she started to talk about it. Tallulah's willingness to confront her family's reality of hereditary breast cancer and share her story changed her own life and her family's trajectory. Stories are powerful tools for communication, and they can be powerful tools for human connection and motivation. And in medicine, stories can save lives. Hi, I'm Dr. Philip Day. I'm a medical ethicist and a member of the Family Medicine Education Consortium, or FMEC. Thank you for joining the Family Medicine Education Consortium's Confidence in Hereditary Cancer discussion series. In this lesson, I'll introduce you to what narrative medicine is and how it can help family medicine practitioners improve the way we care for and interact with patients. We'll also take a look at the principles and history behind narrative medicine. Then I will leave you with concrete steps you can take to start integrating narrative medicine into your own practice. This series was created with family physicians in mind, although we welcome anyone to join us in learning more about the powerful tool of narrative medicine. Incorporating narrative medicine into family medicine practice offers several benefits. First, it allows healthcare providers to gain a deeper understanding of patients' experiences, emotions, and values, leading to more personalized and patient-centered care. Second, narrative medicine enhances communication and empathy, improving the doctor-patient relationship. Third, it promotes a holistic approach to medicine by considering not only the physical symptoms, but also the broader context and social factors influencing patients' health. Narrative medicine, when applied to something like hereditary cancer risk, as we saw in Tallulah's story, can enhance the delivery of holistic and patient-centered care. We've seen a growing number of medical schools and residencies incorporating narrative medicine into their programming. However, many family physicians and other healthcare providers may not know how to use it in their own practice. In a recent learning collaborative of 9 family medicine residency training programs conducted by the FMEC in the Northeast United States, 70% of participants reported no formal training in narrative medicine prior to the collaborative, and nearly 100% reported that they wanted to learn more about narrative medicine. Now let's take a closer look at what narrative medicine is and how it developed. Narrative medicine is an interdisciplinary field that combines the art of storytelling with healthcare. It falls within the broader category of the medical or health humanities. Health humanities are grounded on the notion that knowledge, facts, and information can also be gleaned from sources outside of the biomedical, biological, and basic sciences. Narrative medicine focuses on understanding patients' experiences, emotions, and perspectives through personal narrative. Beyond attempts to reach accurate diagnoses, narrative medicine aims to address the relational and psychological dimensions that occur in tandem with physical illness. The art of telling and listening to stories has a long history in healthcare. More than 2,000 years ago, Hippocrates articulated one of the founding principles of narrative medicine, stating, "It is more important to know what sort of person has a disease than to know what sort of disease a person has." Within the United States healthcare system, we find narrative medicine promoted as early as the Flexner Report over 100 years ago. The Flexner Report, published in 1910, is a landmark report of medical education in the United States and Canada. Many aspects of our present-day American medical profession emerged from this report. The Flexner Report mentions that chemistry, physics, and biology give medical providers one set of facts, but that another set of facts is also required. According to the report, there is an, quote, apperceptive and appreciative apparatus to deal with other, more subtle elements. Specific preparation in this direction is much more difficult. One must rely for the requisite insight and sympathy on a varied and enlarging cultural experience. Medical humanities, and specifically narrative medicine, are pathways to these more subtle elements. Our modern concept of narrative medicine comes from Dr. Rita Sharon and her influential essay in the Journal of the American Medical Association over 20 years ago, entitled Narrative Medicine, a Model for Empathy, Reflection, Profession, and Trust. Dr. Sharon is a general internist who has written extensively on narrative medicine. She is credited with expanding our understanding of narrative medicine, both within the literature and within medical training. In her 2001 essay, she tells us that what physicians need and what we should cultivate through training is narrative competence. The effective practice of medicine, says Dr. Sharon, requires narrative competence. That is, the ability to acknowledge, absorb, interpret, and act on the stories and plights of others. Medicine practice with narrative competence, called narrative medicine, is proposed as a model for humane and effective medical practice. According to Dr. Sharon, narrative competence gives us insight into what she calls the four main narratives in medicine. Let's talk a little about each one of these. The first narrative is between the practitioner and the patient. The second narrative is between the practitioner and themselves. This is also known as reflective practice. The third narrative is between the physician and colleagues. Finally, the fourth narrative is between the physician and society. The first narrative is between the practitioner and the patient. The patient visit is essentially a story, a state of being or recounting of actions that gets communicated by the patient to the doctor, told in words, gestures and expressions, and even silence. Our role as healthcare providers is to practice diagnostic listening. Good diagnostic listening uses our own memories, curiosities, interpretive powers, and knowledge of other stories to identify meaning in this story. Narrative competence, in this case, is cultivating the skill of diagnostic listening through empathetic engagement with patients, which is a way to establish the therapeutic alliance and to engage patients more effectively. The second narrative is between the practitioner and themselves. This is also known as reflective practice, in which we, as physicians, are aware of and reflect on our own emotional responses to patients, our own life journeys, and our own experiences. Narrative competence in this case means that, rather than practicing from a place of detached assessment, practitioners engage more fully with patients and recognize commonalities in our community. The third narrative is between the physician and colleagues. As physicians, we learn from and rely on each other. After our core medical training, we gain practical knowledge and grow in our care of patients by sharing stories and experiences with other healthcare providers. We rely on each other for help, but also for honesty and critique. Our interactions with one another are essentially stories. Professionalism, for example, is an agreed narrative. How we understand what a good physician does and who a good physician is based on our observing and critiquing behavior that is unprofessional or that tests the boundaries of professionalism. It's a narrative that's ongoing, that changes, and that adapts over time and with individuals. Narrative competence, in this case, means recognizing that storytelling is useful among physician colleagues, in both teacher-learner settings and within a practice team. For example, medical educators often use stories to show, rather than tell, how they managed challenges that their learners may encounter in the future. Complex biomedical information becomes more memorable when it's given a human context, and stories have a place within care teams to help them get through traumas and to develop resiliency. Finally, the fourth narrative is between the physician and society. Society imbues medical practitioners and the medical field with a significant amount of authority. On the flip side, this can also leave a lot of room for mistrust of that authority. Society needs to have effective conversations about its medical system and challenges within that system. And these conversations come from and create stories. Dr. Sharon suggests that, through narrative medicine, physicians must find ways to talk simply, honestly, and sincerely with patients, families, other healthcare providers, and broader society. These conversations are not the place for scientific or rational debates. Instead, these are vulnerable and at times challenging conversations about meaning, value, and courage. We get to this place through narrative medicine. Narrative competence, in this case, means listening to people's stories and retelling these stories and the lessons from them to society, policymakers, and our elected officials. So how do we build this narrative competence? One simple and enjoyable way is by immersing ourselves in stories through a variety of media. For example, by reading books and watching films, especially those that touch on the health humanities. We're exposed to others' perspectives and experiences. When these lead us to develop deeper understanding and empathy, we cultivate narrative competence. Another way of developing narrative competence is through self-reflection. We intuitively interpret our own experiences through a narrative lens. By reflecting on our own story, we learn more about ourselves and others, our interpersonal or intersubjective relationships, and about the meaning that we create through those relationships and those stories. We can also cultivate narrative competence through practicing reflective writing and creating stories and art ourselves as physicians. This appreciation for storytelling through art can lead us to appreciate other expressions of knowledge on patient care outside the biomedical perspective. The Story Center website includes examples of healthcare providers reflecting on their experiences with hereditary cancer conversations. Story Center is a nonprofit organization that uses personal narratives as tools for reflection, community education, provider training, and policy advocacy. Visit their website to hear how Dr. Rebecca Kaltman supported her patient through a breast cancer diagnosis, or how Karen Kwok, a nurse practitioner, became a caregiver for her mother diagnosed with aggressive breast cancer. I encourage you to watch these and other videos and use them as a springboard to reflect on your own stories. As family physicians, we are well suited to develop narrative competence. After all, family medicine is informed by a psychosocial model. As family medicine providers, we take a patient-centered perspective towards medicine and look for the whole patient story. This highlights the inner subjective and interpersonal domains of medical practice. Using chronic pain as an example, let's look at how the narrative approach can complement a more traditional clinical diagnostic approach in medicine. On the left side of the chart, you see the process for taking a patient through diagnosis and treatment, where the physician does a visual analog scale and then has the patient quantify their pain intensity. The result is a number that gives us a quantity or intensity that can be tracked over time. On the right side, we see the narrative evaluation process. Here we ask the patient about their suffering and the impact of the pain on their lives. This information provides a complementary perspective. The physician-patient interaction becomes the story of an individual rather than just a patient and a number. Understanding and utilizing narrative medicine can be transformative in family medicine practice. By harnessing the power of storytelling, healthcare providers can delve deeper into their patients' experiences and understand them on a more profound level. This approach fosters empathetic connections and helps us deliver personalized and holistic healthcare solutions. Now that you know the principles and a little of the history behind narrative medicine, let's explore 6 steps you can take to use narrative medicine in your own practice. 1. Encourage patient storytelling. Create a welcoming environment for patients to share their stories, using techniques such as reflective listening and open-ended questions. 2. Document and analyze narratives. Develop a system for collecting and analyzing patient narratives in order to identify common themes and insights that can inform your patient care. 3. Integrate narratives into care plans. Use the narratives patients share to inform their treatment plans, set goals, and ensure personalized and patient-centered care. 4. Share success stories. Highlight examples of how narrative medicine has positively impacted patient outcomes in your relationships with patients in your practice. 5. Practice continuous improvement. Regularly assess the impact of narrative medicine on patient satisfaction, provider satisfaction, and overall practice outcomes, and make adjustments as needed. 6. Be a lifelong learner. You're already working on this one by watching this video. Now continue to look for resources and training to familiarize yourself further with the principles and techniques of narrative medicine. One great resource that will help you continue your learning journey is the CDC's Bring Your Brave website. Bring Your Brave is a public health campaign designed, in part, to make the practices of healthcare providers more patient-centric. Bring Your Brave provides patient education about breast health and breast cancer risk, with an emphasis on detecting cancer among women under age 45 and educating women at high risk for early onset disease. Bring Your Brave materials use a series of first-hand stories from patients and providers, as well as interactive tools like conversation simulation. Tallulah's story, which we viewed a clip from at the beginning, is among them. The campaign materials are designed to engage both patients and healthcare providers in more effective ways to discuss hereditary cancer, improve early detection, and reduce mortality. I hope this video has been a helpful introduction to what narrative medicine is and a little about its history. I also hope that we've been able to demonstrate the insight that narrative competence gives us into the 4 main narratives in medicine. Finally, I hope we've inspired you to take steps to improve your own narrative competence and further integrate narrative medicine into your practice. Thank you for joining the Family Medicine Education Consortium to learn about the background and use of narrative medicine within family medicine. And be sure to check out our additional videos that are part of this Confidence in Hereditary Cancer discussion series.